Welcome to our session, Localised Scleroderma in Children and Adolescents. My name is Jonathan Lord and I work for SIUK and I am your host for the session. Can I please remind you to be muted with your camera off during the session? Please do not record, screenshot or photograph the session. So our speakers today are Clare Pain, Dr. Clare Pain, joined by colleagues Lindsey Clarke and Katie Dobson. Dr. Pain is a paediatric rheumatologist at Alder Hey Children's NHS Trust, and she is also an NHS researcher. 80% of her time is spent patient-facing and 20% on research. She is co-chair of the UK NIHR versus Arthritis Paediatric Rheumatology Clinical Studies Group, which facilitates research in children with musculoskeletal conditions. She has led multi-centre and international work in rare conditions such as Behçet's and scleroderma. Her motivation is to do research to improve care and outcomes for children affected by musculoskeletal conditions. Lindsey Clarke is Senior Rheumatology Occupational Therapist, also at Alder Hey Children's Hospital. Since qualifying as occupational therapist, she has spent time working across outpatient and inpatient services at Alder Hey, developing a sound knowledge base for paediatric care. Lindsey's position within rheumatology means she has worked with children with inflammatory and non-inflammatory conditions and enjoys helping people achieve independence in their activities. We're also joined by Katie Dobson, who is Occupational Therapy Manager at Alder Hey Children's Hospital. Katie has worked in community paediatrics before her role in rheumatology, which started over 6 years ago. And she has been instrumental in setting up the occupational therapy service for rheumatology at Alder Hey. Over the years, she has worked with a large number of children with both inflammatory and non-inflammatory conditions. And early this year, she made the move from clinical practice into management. However, she still maintains 2 days a week within the rheumatology team. So they are our presenters for today. And I just want to quickly go over our process for questions. So you'll be able to ask our presenters questions via the chat function. And we will try to answer as many of those questions as we can within the time available to us. So all that's left for me to do is now to hand over to Clare, Katie and Lindsey.
Thanks very much, Jonathan, and thanks everybody for turning up today. We thought rather than do a presentation, we'd talk around the questions that you send to us, but we just wanted to talk a little bit about our roles to start with. So as Jonathan said, I'm a paediatric rheumatologist, so I'm one of the consultants here at Alder Hey. And depending how your child's affected, you probably see a paediatric rheumatologist, but your care might be led by a dermatologist as well. And sometimes you'll see people together. So they're the sort of main doctors involved in localised scleroderma, but depending on how it affects, you may see other people such as plastics teams, orthopedics. But I think the key thing, as well as the doctors, is the rest of the team that help support children and families with localised scleroderma. So I'll pass on to Katie and Lindsey to explain a little bit about the roles of some of the other people that you may meet or may have met.
Sorry, we had unmuting issues there. Really sorry about that. So yeah, I'm Katie Dobson. I'm one of the occupational therapists. Well, I'm the occupational therapy manager here at Alder Hey with clinical background in the rheumatology team. I'm joined by Lindsey Clarke. So we're just going to give you a little overview of our role with children and young people within this team. So we work very much part of the AHP MDT team alongside the medical team, and again, as Dr. Pain's just said, depending on how your child is affected, depends which members of the team you might see or your child may see. So they may see one of our physiotherapy colleagues if they're looking at the range of movement, the strength, the stamina of your child's muscles and the general well-being in terms of stamina. They may also see one of our psychology colleagues looking at the emotional impact of the condition and managing that emotional impact on a day-to-day basis. As occupational therapists, we're uniquely trained in both physical and mental health and are able to provide support to help your child cope with the physical and emotional aspects of the condition. We work really closely with our physiotherapy and psychology colleagues. However, our focus remains on those activities of daily living, those day-to-day tasks, looking at what you want and what you need to be able to do and promoting that independence in function. Okay, I think we're handing back over to Dr. Pain now, are we? To answer some of or to Jonathan to look at some of those questions that have been sent in.
Thanks, Katie. I was just going to start and say that we're talking about localized scleroderma today. Scleroderma does cover sort of two areas, localized and systemic. In children and young people, the localized is the most common. So out of 100 children with scleroderma, about 93 will have localized and about 7 systemic. But both the conditions are really rare. Localised scleroderma in the UK, about between 60 and 80 children and young people a year develop it. So it is a rare condition, one that your GP's probably not seen before. And that's why you often come to specialist centres to see teams who are used to dealing with scleroderma. We've, I think, had some questions already through to us, which we'll talk to. But again, if you've got any questions as we go along, please put them in the chats and Jonathan will be keeping an eye on those.
Okay, so should we start with our first question? What are the different types of localized scleroderma?
Great, thanks, Jonathan. So localized scleroderma really sort of starts in the skin and goes sort of in some people can go into the tissues, and some children and young people just starts within the skin. And it's described depending on what parts of the body it affects. So in children, one of the most common types is what we call linear. So that's a line of affected tissue, often on an arm and a leg, but it can also affect the face. When it's on the face, sometimes it's given different names. So sometimes you can have a bit of scleroderma that affects on the scalp. That's sometimes called en queue de Saba. Sometimes it can affect the whole of one side of the face, and that's sometimes also called Parry-Romberg. Scleroderma is confusing because you've got lots of these different terms, and then sometimes if you've got more of a patch than a line of affected skin, it can sometimes be known as morphea, and that can be within the skin itself, and sometimes it can be described as deep. Sometimes you can have those patches all over the body, and that's known as generalized, and some children can have more than one type. Thanks, Jonathan. Okay, next question.
Okay, and how is localized scleroderma diagnosed?
So it depends a little bit on how it presents. So it's often a clinical diagnosis, but so by looking at the skin by people that are used to looking at it. Sometimes it can be a little bit difficult and it can mimic other things. So sometimes a skin biopsy is taken, and some of the children that we've seen have seen dermatology and had a biopsy before they come to us, and the diagnosis has already been made. Blood tests aren't very useful. So it's yeah, either on the appearance or on a skin biopsy if something's a little bit unusual or people aren't quite sure.
Okay, and we have a question. How do you know that localized scleroderma is active or not? Yeah,
this is a really, really good question. So we'll come on to some of the medicines that we use to treat scleroderma, but they're useful in the active phase. What we're trying to do is switch off inflammation. And what we want to know is whether scleroderma is still active and those medicines will work, or whether what we're seeing is sort of burnt out lesions that are no longer got inflammation within them. People have used lots of different tools in the past. So one of the tools that's most common now to use in the UK, but also internationally, is actually a skin score, which doctors can use in the clinic room. And that looks at findings in the skin. So whether there's redness to the skin, whether the edge of the skin feels thickened or inflamed, and whether it's any patches are getting bigger or enlarging. So that's one way that actually it's been shown to actually be a very good measure. We also look at, some people have used more clever tools such as an infrared camera, laser Doppler, but actually it looks like the skin tool that we use in the clinic is probably as good as some of those measures, but your child might have gone and had sort of some infrared pictures or thermography taken as well. But it's been something I think that's slowed down the care in scleroderma, because it's been quite difficult for us to pick that out, but this new skin score seems to be very good at picking both sides, and it's quite easy to teach people to use, and therefore you don't need any specialist equipment, so it can be used by anybody in any clinic.
Thank you, Claire. And our next question is, how can puberty affect localized scleroderma?
Yeah, so we don't actually know fully. So we know that puberty can, with the change of hormones, particularly with autoimmune disease, which localized scleroderma is that you can see a role of hormones causing autoimmune disease. So we can see children that present at puberty. We often don't see a lot of change as you go, if you've had a diagnosis before puberty and then go through puberty. We don't tend to see a lot of changes with severe scleroderma getting better or worse, but it can in some patients. I think the thing to think about, and we'll probably move the question on to Katie and Lindsey, is actually that sometimes going through puberty is quite a difficult time and brings up other challenges which may impact the child and young person as who's going through who's got scleroderma. Katie and Lindsey, I don't know if you want to comment on that.
Yeah, Claire, it's very unique to the individual, and as each life stage changes, it throws different challenges in terms of functional challenges, in terms of independence challenges, and we look very much in terms of treatment at an individual. We can't say, well, we have some overarching principles that we would use in terms of management for scleroderma, but it's so individualized, especially from an OT perspective. What's important to that child or young person, because it's not one size fits all. Puberty throws its own challenges in every element. We're hitting high school, we're looking at the challenges that school presents, we're looking at the challenges from a body perception perspective, especially as we go through puberty and the body's changing, the demands on the body are changing, and we're looking at how we can compensate really, in terms of where that lesion may be, how that's affecting that child or young person at that stage in their life. Anything?
No, I think that's fair, and it's about having them open and honest conversations with family and children, allowing them to explore thoughts and feelings, and whether we then link in with the wider AHP team to help that support.
Okay.
Lindsey, would you just explain what we mean by AHP? Because I think probably a term that we're familiar with, but I'm not sure if everybody would.
Sorry.
Yeah. So that's us using the terminology that we're used to. So it's the allied health professions. So that tends to sit with your physios, your dietetics, your occupational therapy, psychology. So it's the therapy side of the NHS teams.
Yeah, it's the professions allied to medicine. So we're the add-on bits that look at the other bits of your child, looking at every other bit that can't be managed by one of the doctors. Okay.
Thanks, Jonathan. Shall we move on?
Thank you. Yes, so we spoke a little bit about puberty and how that interrelates with scleroderma. So what are the main causes of localized scleroderma in children and adolescents? Yeah,
so again, this is an area that we still don't know a huge amount about. So we do know that there's sort of multiple causes. So it's not a genetic condition, you don't inherit it. But if you've got other autoimmune diseases in the family, you might have a sort of genetic predisposition to scleroderma. But what then happens is you need to have something called a sort of a second hit. So your immune system needs to be triggered to then cause the inflammation in the skin and tissues. And that may be a viral infection. We know people that have had sort of significant other illnesses, and then within the months after that, when they're recovering, they've developed scleroderma. We've had a few patients that have had quite traumatic incidents, so they've had a car crash or something like that. But in some people, we don't know what that sort of second hit is. So it's still an area that we're trying to understand much more about, and that needs much more research into that. We think the causes are probably similar to adults as well, but why very young children develop scleroderma, we're not too sure. From some of the work that we've done in other disease areas such as lupus, the younger that you present, it might be that you potentially got more of a genetic risk to developing scleroderma. So actually by studying young children, we might learn more about how scleroderma, what the causes are of scleroderma, which might then be applicable to adults as well. So it's an area our team are keen to explore. We've been linking in with our colleagues in the US who've also been doing some quite nice work looking at how the immune system's working, but also we think looking at genetics, and then that might help us work out treatments to try and turn off disease very early on as well, but an area that needs much more research into it.
Great, thank you. We've had some questions about treatments. Before we go to that though, there was a question about diagnosis, and so it was, I was diagnosed as an adolescent and wonder if being diagnosed earlier in life means the condition is statistically likely to progress further in later life compared to if it was diagnosed later.
Yeah, again, an excellent question, which we don't fully know the answer to. So there are some studies that have been published that look at young people and children and then what happens to them in adulthood. The problem is that if you have mild disease or you no longer see a specialist, you often therefore won't be in these studies. So all they're capturing is sort of the worst disease areas. So we don't know that children and young people get worse disease than adults. What we do know is that they get more likely to have the linear disease, so the affecting all the way down one limb, rather than the patch of morphea, and that disease can impact more, particularly in growing children, because what we're worried about is the tissues getting tight, and then we can see that arms or legs or even facial growth can be impacted. So the aims of being quite aggressive with treatment in children and young people is to allow growth to happen normally as well. So that is some of the differences. And I know Katie's got her hand up, so I'm going to go over to Katie.
It was only to add one sentence in there, Claire, just to say it's interesting to consider how we manage the functional impact on an earlier diagnosis. So if we manage from a physio, from an OT perspective earlier, and those strategies are in place, and enabling young people to self-manage functionally, do we have better outcomes as we transition into adult services through adolescence? That was my one chip in, Claire, sorry to interrupt.
No, and I think that's really important. So the children and young people we see that have a lot of difficulties are those that have had a long time to get to a diagnosis. So the earlier that you can get to a specialist, get a diagnosis, use the medicines, but more importantly is have input from physio and OT and the rest of the team to try and reduce those long-term impacts and to allow as much normal growth and development as possible. So that is really, really key.
Great, okay, and so moving on to treatments, what are the most effective treatments for localized scleroderma? And that ties into another question we've had, which is, what is the gold standard treatment? Can you go the methotrexate route without steroids?
Yeah. So in children and young people, the gold standard of treatment is methotrexate, but methotrexate can take about 3 months to actually work. So depending, if you've got very mild disease, we may just use methotrexate, but that's quite unusual. We often will use steroids because they work really quickly to switch off the inflammation while methotrexate's coming on board and working. The way that we give steroids might be via a drip, it might be via tablets. I think the problems that we know is that steroids have a lot of side effects. So we're trying to limit how much steroid we give by turning off disease as quickly as we can. At the moment, there's only been one, what we call a randomized study, and that was of methotrexate. So that was where everybody got steroids, and then half the people got methotrexate and half got a placebo. And then the evidence we've got for other medicines comes from smaller studies as well. So in the UK, we still need to use methotrexate as the first drug of choice with steroids, but trying to limit our side effects. So it's always a balance of trying to use the minimal amount of medicines we can and minimize side effects whilst controlling disease too. Methotrexate is something that we call a DMARD, which means it's been around for a long time, but it's often a tablet to liquid or sometimes an injection under the skin. There's another tablet or liquid called mycophenolate, which we often use second line in the UK. And then the newer medicines, which are known as biologics, so they've been designed to block certain parts of the immune system. We've got some evidence to suggest, particularly from some of our adult studies in systemic scleroderma, that some of these medicines could well be very good to use in localized scleroderma. But in the UK, until about a month ago, we've struggled to be able to use those medications because of national commissioning. I'm really pleased to say that we've just had approval of a medicine called abatacept, which is a biologic, which means we've now got more options for treatment, for medications for turning off inflammation. Depending a little bit, if you've got a small patch, you might actually get some creams for scleroderma, so you might get some topical steroid. Sometimes our dermatologists will use UV light therapy, but again, we have to be very careful with children because of the risk of skin cancer, so that's sometimes used in some cases. But I think the real keys are, as well as switching off inflammation using these medications and trying to minimise medication side effects, is then working with the rest of the team to make sure we're maintaining and improving function and reducing the impact of scleroderma on all aspects of the child's life. Katie and Lindsey, do you want to come in there at all?
Sorry, we decided who's talking. We're looking at, as Claire says, looking at those practical steps to reduce the impact on the child's life. So we thought we'd just talk through a few of our tips and strategies for managing those practical issues.
Certainly. So I think one of the key aspects of managing when they turn up in clinic with us is from a fatigue management point of view. So that can be very specific to one area of the body, especially when we're considering localised scleroderma. However, you need to consider the person and the child as a whole and the impact of fatigue holistically on that person. So tips for managing fatigue for us is that you might use them larger muscle groups to complete activities. So an example of that could be opening a door with your shoulder rather than them smaller muscles in hands and wrists. It's very much effective alongside a physio program, and we work quite closely with our physio colleagues and often see children jointly to make sure we've got that joined up approach. Working on keeping their muscles strong will certainly help, and we encourage all children to be as active as possible to help with that. One of the other aspects that falls under the fatigue management is being able to pace activities, and we talk about that a lot in our clinic. So spreading activities out throughout the day, the week, the month, rather than having really busy days and really quiet days really helps. In children, this can be a real challenge, and we certainly see that adults need to take the lead in this area. Good communication with school for pacing activities is very important, and that's something that we certainly help with. Moving on to a specific part of the body, if there was localised scleroderma from a hand point of view, we might use hand therapy, looking at assessment of grip strength and movements within them hands, considering how reduced strength in hands are going to impact on function. So they're going to impact on them daily tasks of being able to wash, dress, handwriting in school. We do occasionally splint if indicated, so using thermoplastics or neoprene splints, and we only ever use splinting really to keep them functionally active, not to restrict them joints. We want them moving, we want that movement there. Fine motor activities and assessments comes under the hand therapy umbrella, looking at sort of handwriting, dressing, cutting up foods and increasing the function within that area. We'll often use larger muscles or compensatory approaches, which will be talked about a little bit later.
Yeah, just to follow on again, following along this thread of how we manage in terms of treatment, we don't just look at hand function, we look at the child or young person as a whole. We'd consider, you know, if the lower limbs are affected by a lesion, we'd be looking at the impact on mobility and looking at the impact that restricted mobility might have on the child functioning, the young person functioning in the school environment, in the leisure and hobby environments, and especially at home. We might look at some equipment for walking aids if needed, which leads on to sort of that compensatory approach. We don't, as a general rule, look at a compensatory approach, and by that I mean, you know, adding things in, adding little bits of equipment, adding, you know, as I say, a mobility aid or a splint as a compensatory approach. We would use as first line really making things larger, making things easier for a child and young person to hold, looking at strategies to make life easier, enable that child or young person to be able to take part in the activities that they want and need to do. I think quite importantly to add here, which is often something that we often forget on our sort of day-to-day, is the importance of positioning and posture. If an upper limb's affected, how does the child or young person view, or how do you view that limb? You know, we don't want it sat at the side of you when we're doing a fine motor activity or when we're eating and drinking. Positioning that limb on the table alongside, making sure the child's simplistically sat with both feet on the floor during school, so they're getting equal weight bearing. That we're promoting that symmetry. We're looking at the sitting position. This again is very much working closely alongside our physiotherapy colleagues. We also, and it sounds a strange treatment really, but again, when we're looking at the child or the young person as a whole, we're looking at sleep and relaxation. It is very much linked in with a holistic approach, promoting good sleep hygiene, and it is a very much core role of an OT, which isn't specific to the management of scleroderma. And I also think, before we finish that question, sorry for rambling on a little bit about treatment from a therapy perspective, but we look very much at transition, providing that link between adult and paediatric services, where you've been managed very much, you know, from a medical perspective, from a allied health professionals, the professions joined in perspective, and going into the wilder world of adult services, not just from a hospital and a medical perspective, but in terms of the wider transition into college or into employment or into that change in social groups. Okay, thank you.
Thank you, Katie and Lindsay. I think everyone found that really useful. So just going back to some of the treatment options, we've had a question regarding side effects. So are the side effects for Abacet less than methotrexate? I hope I pronounced that right. So
methotrexate is a good drug in a lot of patients, but it can have quite significant side effects. And I think the side effects of methotrexate are probably well known to a lot of the families that have joined us to hear. So one of the major side effects of methotrexate is feeling sick or being sick, and this can have a huge impact on children and young people. This isn't a side effect that we particularly see with mycophenolate. Mycophenolate can cause a little bit of tummy upset and diarrhea, but often when you first start it, we don't see that feeling sick or being sick with abatacept. It's very unusual. So it has a better side effect profile in that side. It probably dampens down the immune system a little bit more, but we don't see a huge amount of problems with infection with any of these medications in children and young people. It's quite rare to really run into trouble, but we do need to think about and advise about things like vaccinations on these medicines.
Okay. And another question we've had is how many children, young people under your care require second-line treatment with mycophenolate in addition to methotrexate, or do most have a good response to methotrexate alone?
Yeah, so when we look at the clinical study, about 2 out of 3 children responded to methotrexate. When we actually an audit looking at children and young people in the UK, and we saw that about half of the children needed to have additional treatment. And again, this is amongst paediatric rheumatologists that we did the audit, so we're probably looking at the more severe end of the spectrum. So there are a number of children with quite mild disease that are managed by dermatologists that can be managed with topical treatments, but it's about half that go on to need additional treatments in the UK from when we've looked at that in the past.
Okay, and then we've had a question around supplements. Is there any merit in children taking high dose vitamin D?
Yeah, so we should all really probably take vitamin D. We get quite surprised if we check someone's vitamin D at Alder Hey and it's actually in the normal range, because if you make vitamin D from sunlight, and it's quite, although we had a nice week of weather the last week, it's quite unusual to get a lot of sunshine in the UK. And also because of our worries about skin cancer, we're often putting suntan lotion on children, which is the right thing to do. Vitamin D is important for your normal immune function. So we would really recommend that all children are on an over-the-counter vitamin D medication. There isn't much evidence to suggest that higher doses than those that you get in sort of multivitamins are recommended unless your child's been found to be vitamin D deficient, and then the hospital will advise on vitamin D dosing. But we haven't seen very much evidence that higher doses are of benefit to the immune system. And also you can cause trouble if you're on too much vitamin D as well. So it's probably worthwhile a conversation with your doctor to see, as your child had their vitamin D level checked, and having a bit of advice about vitamin D dosing.
Thanks, Claire. So we don't have any questions outstanding at the moment, and we're in the last 10 minutes of the session. So is there anything we haven't touched upon which might be worth chatting about?
Katie and Lindsay, was there anything else that you wanted to mention?
I think we've covered everything we prepared, really.
Okay.
I think, sorry, Claire, sorry. My one final comment was, as I said early on in the presentation, everyone is individualized. Everybody who is impacted on by this condition has their own needs, has their own goals and aspirations, and I think it's important that we do manage people as individuals. That was all.
I think, I guess, and on the same lines as we've mentioned, I think all the things that are good for children that haven't got scleroderma are good for children with scleroderma. So thinking about healthy eating, exercise, good sleep, mental health, good friendships and support are really key. I guess the one thing we haven't touched on, which people may ask, is I guess the role of surgery. So we've sometimes need our help from our orthopedic colleagues if we've see children that have got quite tight muscles or struggling very much functionally despite having physio and OT input. We have had some children that need to have orthopedic surgery, so sometimes that's very, very rare, but sometimes is necessary. We've also been more closely working with one of our plastic surgeons at Alder Hey. So sometimes we have been doing something called fat transfer, where you take fat from another part of the body and put it around the affected area. So we've done this in, for example, some children that have had facial lesions, someone that had a foot lesion that had a very an unusual foot position that meant that the bone was rubbing on shoes, so they would put some fat there to try and recover the position. And also actually in a teenager that had a bit affected the shape of her buttock, which she was really conscious about. So that is an area that we're learning more about as well.
Thank you, Claire. So we have another question which might have to be the last one. You talked earlier about the onset of the condition being triggered by something like a car crash. Does that mean there's a connection between children who have developed PTSD and scleroderma? Oh, sorry, and systemic scleroderma. Yeah,
not that we're aware of. There haven't been any studies that have specifically looked at that. So, and it doesn't seem to, it seems to have been more sort of a physical trauma than the mental trauma. So even if it's been for example, a patient that actually had a pancreatitis who then developed scleroderma further down the line. So it's been sort of another illness rather than a mental health illness, more of a physical illness that seems to have triggered. But again, I don't think there's been very large studies looking at that, but from our experience of the people that we see coming through our clinic, we haven't picked up on that.
Thank you, Claire. So I think that we're getting quite close to the end of our session now. So if anybody wants to say anything as a final word, then that's probably now's the time to do that. I think.
Was that to us or to the? Oh,
it was to you. Sorry.
Sorry.
Claire, Katie, and Lindsay. Yeah.
I guess I thank you very much for giving us the chance to talk today. And I think we're really keen to work with SR UK. So if there's things that you think would be helpful for children and young people, or that doesn't exist at the moment, different ways of talking to and reaching out to families, I guess please contact our SR UK. There might be, because I know that it might be that children and young people would like to communicate in different ways as well. So I think that's probably all I was saying. Just a big thank you. Katie and Lindsay, shall you? Yeah,
just to echo that, please get in touch via SR UK to if there's anything that you feel that we're missing or that we could work alongside to develop. And thank you very much for the opportunity today.
Thank you, Claire, Katie and Lindsay, for your time as well. Really big thank you from SR UK. And just to really echo what you said, I think we've been able to get to everybody's questions today. But if people do want to get in touch by another way, they can go to our website, and on there's the details for our helpline, and they can contact our information service. So please feel free to do that. But otherwise, that's really helpful. Thank you so much for your time today.
Thanks, everyone.
Okay, so that brings this session to an end. Thank you, everyone.